Yeah. Hi there, good evening, and welcome to the third in our series of launching a longevity clinic. Thank you for those who have joined us. Thank you for those who are missing the football or missing the nice weather to actually dial in live and join us as we talk about TRT, HRT, all things hormones, and how you can start introducing these treatments into your clinic. Now, I'm really honoured. So, my name is Dr. Matt Pywell, and I'm really honoured to be joined by my colleague again, Dr. Abs.
Hi, Dr. Abs. I think you've probably had enough of me by now, but here I am again for the third time, and we're joined by Dr. Harriet as well.
Hi there, guys. My name's Dr. Harriet Turnbull. I am a GP by background with lots of experience in menopause and also an aesthetic doctor, so really looking forward to this chat about all things hormones this evening.
Thank you very much for joining us, Harriet. So it's been great. The reason we're a couple of minutes late is because we've been talking all things hormones because we've just been sat down together, and I've been having to encourage you guys to actually just wait until we've got the webinar and people are live and watching us, because we've been having some really interesting discussions about the current state of TRT, HRT, menopause treatment, andropause treatment, performance optimization, steroid use, all of these sorts of things. And that's all the things that we're going to be covering today. And we're also going to be spending a bit of time at the end of the webinar to talk more about CQC regulation for these treatments and more longevity treatments, more about our courses and more about how you can start implementing these treatments into your clinics. So do stay tuned. I'd ask you to start putting your questions into the chat now, because as you know, with all of our webinars, they're very interactive. We want to know what you guys want to know. So if you put all your questions in the chat, we've already got some that have come through on socials and on our emails, so we're going to make a start, but please do pop everything you want to know in the chat, and also put in where you're from as well, where you're watching us from. It'd be great to know. So we're going to make a start. So I think the first question that I've got here is really for you, Harriet. So how can you identify the signs or the early signs of menopause?
Yeah, that's a great question. I think this is one of the things that can be really most challenging in clinical practice. So often it's a topic that patients will bring to you saying, I think I might be in the perimenopause or going into menopause. And the more education there's been around this, we're seeing this more. I think that patients are kind of self-presenting saying, could this be menopause? But actually the symptoms around it and those hormonal changes and the drop of estrogen can be quite esoteric and present in lots of different ways, all the way from physical symptoms like night sweats through to depression, anxiety, social problems with alcohol. It can be almost anything, and it's one of those things that could there be something going on hormonally, something you just need to keep in the back of your mind anytime if you're consulting patients. Certainly in general practice, it's a little bit different if you were setting up a clinic that was more towards wellness or hormones in particular, but you really have to keep an open mind, and there's almost no symptom that might not be related. It could be pain. You think their arthritis has suddenly gotten worse out of nowhere when they're 42. Could it be hormones? Could it be that drop in estrogen? So there's a whole host of ways.
I was watching a podcast with an American menopause specialist, and I think they quoted something like 400 symptoms that are associated with menopause, and it really can be anything, can't it?
Absolutely, and particularly I think the social impact is one thing that's often really overlooked, from people just not feeling like they've got much energy or feeling anxious out of nowhere when, I've never been anxious before in my life, and not wanting to engage with their social lives. Sometimes it's turning to alcohol and things because they're thinking, I feel really anxious, maybe I'll have a glass of wine to relax, and then they end up gaining weight. And there's lots of different things. Or actually performance at work is a really classic one, saying that they just can't concentrate, they're just not as good as their job, they're not feeling sharp and quick and having those snappy responses in meetings. So there's lots of different ways, but there's no most common way really.
What
kind of age range do you find you start to suspect?
You took the words right out of my mouth.
Yeah,
I was just thinking, with all these symptoms, when do you actually start?
That long now.
When do you start thinking about menopause and perimenopause?
Yeah, absolutely. So I think again, there's more kind of knowledge out there around this now, because people used to think about menopause when they've been through the menopause. So you're 50 and your periods have stopped. Oh, maybe it's menopause related. Actually, what we know is that a typical menopause is often a transition over a period of about 10 years, and the symptoms don't always go away. And that's what can be really kind of difficult to discuss with your patients, that actually for some women the changes that happen and the symptoms they get can be truly long lasting, even years after their periods have stopped. But from the kind of younger end of things, I think certainly for women from their 40s, it needs to be in the back of your mind, which again in the modern world is a really kind of challenging thing, because what we're seeing on one end is that women are having children later than ever. It's very common, from friends, colleagues, things in London, women having their first children in their late 30s, and then 2 years later they're dealing with symptoms of menopause. So I would say to have it really kind of in your mind, certainly from your early 30s, 40s, but if they are in their kind of late 30s, that's when you're getting into more premature ovarian failure territory, which again is something to consider, but much, much less common. But it's not something that comes on overnight. It can be something gradually creeping in from your early 40s, which people are not always aware that that's the case.
Do you think that noticing a difference in periods is a good sign that people should look for?
It's a really late sign. It's a really late sign, actually. And again, what you'll see typically is that we might notice, periods becoming heavier. But again, if they've had children recently and things, and often are just really busy and distracted, yes, they're knackered, the joints hurt, they don't feel great, they're anxious, but they're also thinking, well, I've got, young children, I've got a 5-year-old and a 3-year-old, of course I am. So it can kind of be masked by other things going on. But the changes in the period, that's often really late stage things, often either less frequent, really heavy periods. And again, that needs to be taken in context of their other hormone history. Are they still on the pill? Because you really need to consider contraception alongside all of these things as well. So there's a lot to consider.
I think it's really important that you talked about how menopause fits in with a lot of these other symptoms, and obviously you've got the pyramid behind me, we can see that sort of stage-wise approach to longevity.
Absolutely.
And I've often seen in our clinic patients actually come in for weight gain issues or mental performance issues. Actually, when you take them back to that beginning of that pyramid and you work your way up and you look at their hormones, you see they're actually in perimenopause. And so when you sort of pick that up, is it quite a shock for patients to sort of realise that maybe they're in the early 40s and they're in menopause? So I can imagine it's quite a big transition for a woman to go through.
Yeah, absolutely. And it's not an easy conversation always to have. I think, especially if the periods are still there and things. And again, people in their 40s, especially now more than ever, are young patients. So it's quite a tough kind of transition, I think. And actually, in that kind of life stage, I think more into your mid-40s to up to sort of age 50, I think there is a lot going on socially as well. It's often a time of change of kids leaving home, divorce, I think sometimes often linked in, to be honest, with hormonal change and things like that, the things that kind of unravel. So definitely.
Yeah, I think it's important to have that complete holistic approach to people. And I think one of the big questions that keeps coming in is, can anyone offer menopause treatment? Is this something you need to spend a lifetime learning, or is it something you can learn on course?
Yeah, so we were having a really interesting discussion around this before. So certainly within my general practice colleagues, what I found this in my last practice was that I was delivering the bulk of the HRT initiation, prescribing, because there's often just among medical professionals a real lack of knowledge and a lot of kind of fear around prescribing HRTs. And I know we're going to talk a little bit later about the studies and the reasons why that is. But actually, as doctors, we're really used to prescribing hormones. For example, we mentioned the pill earlier and contraception. Most GPs would be very comfortable, prescribing a combined hormonal replacement therapy to a teenager to go on the pill, but would be anxious about prescribing it to a 42-year-old who wants it for HRT purposes, which is interesting. And I think it has become, it's very a sort of postgraduate topic, and I certainly didn't learn about it, about HRT, until I was suddenly a GP working in a mostly actually male-led practice, and they sort of said, well, Harriet, as the kind of female GP, was a bit of an expectation there, which is absolutely wrong. And I hate to bash other GPs. It's just that the education isn't built into medical training much of the time.
It's really not, and everything I've learned has been very much postgraduate, and indeed since I've got into longevity, actually we had nothing in medical school, and even talking to colleagues who are obs and gynae doctors or GPs themselves, they say that their entire menopause training, their entire career, may be a few days of covering some of the evidence from the WHI study, which we'll talk about in a bit. But it's really interesting how little it is.
I think it can be done, and again, I think that it is a complex subject for its breadth, but actually it's not that complicated. There's some core principles that I think if everyone as a medical professional kind of understood, it would take away some of the mystery and actually just the poor care that's being delivered. And I think we're seeing such a growing field really in the private sector. It's because with general practice, 10-minute appointments, from the things I've already mentioned, how are you supposed to take a good history and not just patient says, oh, I think my arthritis is worsening. Okay, you're probably right. Let's get you an X-ray. And actually not delving into it and having that, the word holistic I think is a bit overused now, but really taking that kind of multi-system approach is just so not possible in a really overstretched in a healthcare system like this, especially when there's a lack of knowledge behind those that should be the ones detecting it. So we've got to educate the general population and ourselves as well, and get clued up on what is actually a really straightforward topic. Once you get it, it's really straightforward.
Exactly, and the way it integrates so well with the rest of longevity. I mean, longevity practice, people who are entering this relatively new field of longevity medicine are in prime position to really capitalise on the fact that the NHS is really struggling to deal with these. As you say, 10-minute appointments just aren't enough. You can't really see a patient treatment and give them a holistic or a longevity consultation in 10 minutes. So this is where actually, in the private sector, we can offer a full hour. You can talk to patients, really get to know them, get to know where they are now, where they want to be, and how to get them there, and all those sort of things along that journey. So, Abs, let's talk a bit more about TRT and andropause. So, I think first of all, a lot of the questions coming in is tell us more about andropause. Is it a new thing? Is this something that is becoming more common? Is it something that is you see a lot in your clinic?
I think it's something which is becoming ever increasingly more common, as is HRT, as I'm sure Harry would agree as well. Simply because we're seeing it more in the media. Like more and more people are open about. It used to be that people were hiding cosmetic procedures. Then they would be open about cosmetic procedures. And then there was a point where they were hiding, having weight loss drugs or things like TRT, HRT. And now we've kind of gone over that hurdle as well. And they're kind of more open about that as well. So it's becoming more and more known about to the general public. I don't think it's known about in any great level of detail. I don't think many people know about how to do it safely, or that they need to do it under supervision, that it's not super simple.
Safety is a really big thing, isn't it? We were talking about this earlier, and you sort of hear about these people who are just jacking themselves up on tea, right? And they're in the gym, they're huge, they're on steroids and these sorts of things. Like, how do you differentiate that from getting someone back into a normal therapeutic window?
It's a really good question, because when you talk about TRT, to people who aren't looking to do what you've just said and go overboard, they have that image in their mind and they think, no, I don't want that. No, you're not having that. It's like, for instance, put it in a really simple analogy. If you just have a normal sized meal, right, that's just a normal meal. There's a difference between that and eating so much that you vomit, right? We're not trying to go to that level. We're trying to give you what your body is designed to have in terms of the physiological levels. Going overboard is what we would call super physiological levels. That obviously is entirely different, has nothing to do with longevity medicine, is not anything that I think all three of us would ever recommend. But when you do it in a physiological way, in a homeostatic way, you're trying to optimize physiological function. You're not trying to go overboard. So people, I think America's been doing this for a little bit longer than the UK in a more open way, shall we say. They have like anti-aging clinics. I'm sure we've got US viewers actually. I'm just right in the comments maybe if you've seen this sort of thing, but there are very many anti-aging clinics where it's very common to just go in, have a few tests, and then they put you on TRT very easily and very simply if it's needed.
Well, we were saying earlier about you can do that in the UK. You can sign up online, can't you?
Yeah,
you can
absolutely.
Essentially get a TRT prescription online with potentially one blood test or sometimes not even that.
Which is scary, to be honest. I think it's, hormones are not to be tampered with. Like your body needs those as signaling mechanisms. The endocrine system is very complex. Yeah. And messing around with it is going to have severe consequences if you don't know what you're doing and you're just playing with it. Yeah. And so if someone who does a single blood test who hasn't got the time to ask you about your diet and lifestyle, which always, I know we sound like a broken record, but it is important. People who don't ask you about that and your training status, your life history, all this kind of stuff. Yeah. I just would not recommend that at all. I think a proper medical history, full analysis, full range of checks and tests, and then supervision as you go along in a personal way.
That's a really key thing because I think there is access to this and access to steroids and to anabolic steroids and to TRT, and people can get hold of it, not even without necessarily even seeing a healthcare practitioner. Yeah. And it's quite interesting actually seeing how we can, as longevity practitioners, start overseeing this and actually start applying a more medical approach to it to really get this get those ranges in optimal level and actually making sure they're not having any of the side effects and the complications from it.
Yeah, I mean, it's scary how easy it is to get a hold of, right? I think those of you know, we're doing a masterclass in the future based on performance optimization. And immediately that may bring up images of exactly what you said before, of people that just get jacked up. And in some gyms, people just walk around. Yeah. hey mate, do you want some tea? Like it's as simple as that, right? And it's, I would always think, how do people say yes to that? I don't get it.
I see the gym myself. I go for a workout. I know now on a Friday I go for a workout. There's always two guys in the gym on a Friday talking about their T levels and what their current T levels are and what their current latest deadlift is and all these sorts of things. And I've actually started stopping them in a couple of times. I'm like, can I talk to you a little bit more about testosterone, how it fits in with the rest? Not sure I made any friends.
Come to Apex Medical.
Exactly. Yeah.
I mean, just to give people an idea, right, of how overboard this is, because it's hard for the general public to imagine this, apart from just the thought that you don't need that. Well, Dorian Yates, when he was winning Mr. Olympia again and again and again, he was, on performance enhancing drugs. And we know exactly what he was on because it was written down contemporaneously every single time. I have seen with my own eyes people injecting things in gyms more than what Dorian Yates used to win Mr. Olympia, but they are doing it recreationally week in, week out. And that is a scary thought. Even Dorian Yates himself is scared to say that is the way things are nowadays. So, you don't have to inject massively super physiological amounts to make good gains in the gym if that is truly your goal. Like, you can replace things in a physiological way and then optimize, like we teach, things like the diet and the lifestyle and whatever you need to then, go on to competitions if that's your goal. So I really, really advise people not to go down that super physiological route.
I've got some great questions coming in here, and I want to get to these, but just before we do, while we're talking about testosterone, obviously testosterone is not just for men, is it? And actually testosterone is very useful in the treatment of menopause, Harriet, isn't it? And so how can you incorporate testosterone treatment in menopausal patients?
Yeah, that's absolutely right. And I think it's sometimes often really overlooked, so, testosterone is a normal part of female hormone physiology as well. The evidence really for testosterone, its use, is actually around libido, which again is a really overlooked symptom. I think the space that we're really talking about today, more than improving your aesthetic and things like that, it's about how people feel and how they're navigating their lives and living better and that sort of thing. And actually the impact on people's libido, and that can be a combination as well, combined with some genitourinary symptoms as well.
I was just thinking that, so all the sort of type of things you can have.
It's often people don't ask, and GPs don't feel comfortable asking people, how's your sex life? It's not always comfortable for people to ask that, but it's really, really important because it can, again, it just has that impact into lots of different areas of life as well. And it doesn't have really any other proven benefits than that, but it works very well. It works very well.
Do you find that the patients by themselves, when they come to see you, make that connection between loss of libido and HRT, or is it something you draw for them? I'm just curious as to what the demographic is like for that.
Yeah, so I had a very in my menopause consultations, I have a very structured approach. Which includes literally a checklist. I actually find that British people, I think in particular, are much more comfortable with checklists. You say, I'm just going to ask you a few questions. Some of them are going to be really holistic here and ask lots of questions. And some of them are going to be, once you've asked people about, their mood and things like that, and then you move on to, do you experience, vaginal dryness? Do you find that you have have you lost interest in having sex? And once you go through like a tick box questionnaire, people are much more comfortable saying yes, no, sort of, than they are bringing it up themselves. Okay. And actually, as long as you've got a good rapport and relationship with your patient, they really trust you, then they don't mind. Once you ask the question, they're like, oh, thank goodness, I just want to talk about, yes, it's been terrible. And it depends what their baseline was as well, in terms of their sexual function and other things that they, depending on them as an individual. But it definitely improves a lot with HRT. Yeah. So I almost view it as you've got your female hormone replacement with your estrogen, your progesterone, and my testosterone questions, that's always a tack on, and then I usually navigate that into asking about the more genitourinary symptoms as well. You need to cover it all. Yeah.
I find sometimes with the menopausal patients, actually even waiting for that follow-up consultation, you sort of start seeing them, you have that first consultation, you talk to them about the rest of the symptoms, you've got a blood test potentially that shows that they're in perimenopause, convincing them that they're in that, and then you potentially start the HRT regime, and actually when you bring them back, then you can talk more about sort of vaginal estrogen, you can talk about testosterone, and they start to see an improvement in their symptoms, and they open up their mind to it a little bit more, don't they?
Yeah, it's a bit, I was thinking actually earlier, it's a bit like with your, so we talked about diet and lifestyle. If you meet a female patient who is really having absolutely terrible, really overwhelming menopause symptoms, you say to them, why don't you go to the gym a bit more? Why don't you? They're complaining about abdominal weight gain and all this stuff, and they'll tell you, I've tried everything, and they haven't got anything to give. They're not going to be able to. So actually, it's a bit like you mentioned, like semaglutide, for example. It's about that Kickstarter. Get them feeling better, okay, and then actually you might be able to come back and readdress and actually say, I know you said you tried everything. Now you're feeling better, can we take a closer look at that and then go back up that pyramid again from there?
I think people are getting fed up with being told it's their fault. It's their fault they're fat, it's their fault they're in the menopause, it's their fault. And actually what we're starting to realise in longevity medicine is that actually there's a very complex interplay of systems here. We're talking about the gut microbiome, we're talking about the mitochondria and the function of the mitochondria, your own DNA and how that links to things. And actually these are all things that we can target, and we talk about more as we go through our courses, but it's really important to say, tell these patients who have been told for all of their life they're fat because they're fat, and they're in menopause because they're in menopause, get over it. Actually, there are things that we can do to treat it and make their quality of life better.
And I think patients are always so eager to just take that control back and they want to feel better, that's why they're there.
I think it's fascinating. I'm really tempted to go into more and more about this, but I'm really conscious of the fact that it's very interactive. We've asked all people for questions, so I'm going to just go through and ask a couple of questions that have come in. So we've got someone asking about diet and lifestyle. So this is probably going to be for both of you, and Abs, we're going to rein you in for like 5 minutes on diet and lifestyle. So what is a good diet and lifestyle for someone who's in menopause? Maybe Abs, you want to start?
First of all, it doesn't matter whether you're in menopause or not. I think that's the wrong question to ask. It's the question should be, what is appropriate for our species? Like what's peak function on a cellular level does not change from a 20-year-old to a 100-year-old, right? As cells go through mitosis, the telomeres shorten, okay? And when those telomeres get too short, they reach the end of their division and they can't divide anymore. At that point, we have things like the CD34 plus adult stem cells released from the marrow to replace them. That is essentially what keeps us going. When that stops, that is when we die. And we can relate death to, mitochondrial function, stem cells, whatever you want. But what keeps that going is the same principle from the moment you're born to the moment you die. So I think the principles are actually universal, and Harry, I'm sure would agree with me on that. And it comes down to, honestly, nothing exciting, right? Making sure that you're not gorging on processed food all the time, making sure you're not smoking all the time or having too much alcohol.
So briefly, processed food. Yeah. You talk about processed food. People use this term all the time, but how can you tell something processed? What is processed? Because almost everything you get in the shops nowadays has some sort of processing, doesn't it?
If there's a label on it, it's been processed. If you pick an apple from a tree, there is no label, so it's not processed. If you butcher a cow and you take the meat and you grill it, there's no label on it, so it's unprocessed. Anything with a label has been processed. And then there are classes. So something with minimal processing might be something like adding salt to cure it. That's hardly going to kill you, and we need the sodium, frankly. Something like, a plastic-tasting chicken McNugget from whatever is the latest fast food craze. I think that's clearly on the other end of the spectrum. I don't know if Harriet, you've got any, if you agree or disagree. I'm sure you would agree.
No, I think fundamentally, in terms of what is good nutrition and diet, I agree. My approach with patients, I probably go from the opposite direction, which is the end destination goal is going to be eating whole foods that keep you full, that are easy to make, all of that. But my view in is usually finding out about this person and their current lifestyle, and then how we're gonna work that into to be realistic, so that they see results, so that they are then going to be motivated by that. For example, again, is your busy mum of 3, she's very senior in her role, she's 48, she's also dealing with these menopausal symptoms. They're not going to be so interested, I think, in the detail about of the diet and things like that. It's got to be like, can you reduce your calories somehow by what's going on here? Are you late night snacking? Do you work so late you come home at 11 and you're shattered and you just get a takeaway? Actually looking at what is the reality of their day-to-day life. That's where That's where I'd usually start, and then we think about, okay, well, how could we get this to work for you better? And then from there, that's what I would typically advise, is to get into the detail about whole foods, less processed and things like that. good protein, weighing your food. So many patients I've met have never weighed a carbohydrate, they've never weighed their pasta portion, all this sort of stuff that can be really useful. But ultimately realizing as well whether they need additional nutritional support. They basically need a coach. Do they need to go through a more intensive period, which I think realistically would sort out a lot of weight related problems. So just having that proper support and regular input, but it's got to be tailored for their individual lifestyle. Like, it's just not possible for everyone to sort of meet perfection. I think it's quite hard. Yeah.
Was that a pun there? Meet perfection.
Yeah.
and Harriet, tell us, with regards to diet and lifestyle and these sorts of things, with menopause, there's certain things to avoid. There's certain things that you don't want to be having in your diet that might make symptoms worse.
Yeah, I think a lot of the time I'd say to patients, be cautious around this, because there's often a lot of people trying to really sell you stuff that doesn't work that well necessarily around menopause. So generally speaking, I think alcohol is a really interesting one, because it's something that I find really does often creep up for people in sort of midlife. Either through, often actually it's drinking at home, not being able to go out, having something to make you feel less stressed. And that can be a big actually part of what's going on, especially with the anxiety creep that can kind of happen with menopause. But I think in terms of overall diet, it just has to be unique to that individual person. I don't think there's anything they need to particularly go for. Avoid caffeine as well. I've got so many patients who've said they've been actually much more sensitive to alcohol, getting terrible hangovers and things like that, and actually just feeling really, really anxious with caffeine. So again, I would just break it down to their kind of fundamentals originally, but I don't think there's, as Ab said, there's no specific, anyone tells you there's a special diet for this or a special diet for that is often just not the case. I think it's to do with marketing.
I've got a question about what you said about people drinking at home. Do you find that when COVID happened and more people were doing that, did you as someone that treats HRT experience an increase in people coming to you for things like that?
People definitely couldn't get in to see their GP, no, but I think we've seen the aftermath of that, of people having, again, it's just all these things that we talked about, having gained weight, having gained a bit of an alcohol problem, or coming in saying, I've stopped now. Actually, there was an 18-month period where I was just drinking, 2 bottles of wine a night and things like that, and it really crept. It didn't start that way, but it crept up like that over time. Yeah. And it's the worst thing. You can imagine for hot flushes and generally feeling bad, feeling more anxious. It's a terrible combination with menopause. Yeah,
and it sort of escalates, doesn't it? It just spirals then, and it gets worse, and they drink more, and then they're eating worse, and then it's going to make them worse. Talking about just one more question on diet that's come through is talking about intermittent fasting. And what are your thoughts on intermittent fasting in menopause and andropause management, and how does that sort of fit in?
So intermittent fasting, to understand the answer, needs to be separated from the concept of menopause and andropause. It is not something that gives you an improvement in those things specifically. It's something that gives you a systemic change, shall we say, regardless of whether you're going through menopause or andropause. So one of the main benefits is that things like, let's say you've got fat on the liver, whether it's alcohol-induced or non-alcoholic fatty liver disease. The intermittent fasting essentially allows you, through the process of going into things like ketosis, to work off the visceral fat, which obviously everyone wants their organs to work fine, so it's good for that. But when you are having visceral fat and reduced organ function, that clearly is going to have an effect on your hormone landscape, for want of a better word, as well. Number one, because of the organ function reduction. And number two, because when you are storing excess fat, your hormone landscape is going to be completely different. Like if you're completely obese, it's more likely, let's say you're a young male, even though you're in a category, a demographic, which is probably going to have relatively higher testosterone than someone who's much older, because you're massively obese, actually your testosterone could be much lower. Yeah. So if you apply intermittent fasting through to those kind of situations, and you allow your body to reduce that visceral fat, reduce the overall fat to what is appropriate in terms of quantity and positioning or distribution around the body, then you're more likely to have success with improving things like your mood, your energy level, etc., as a result of your hormone levels being optimal as well.
Yeah, and I know both of us do intermittent fasting regularly, and certainly feel the way.
I've stopped now, actually, interestingly.
Oh, really?
Yeah.
Okay, you have more than one meal a day.
So I don't try to do it, shall we say.
Okay. Yeah.
I may find myself in it,
yeah,
but it's not something I aim for.
Yeah,
that's probably a better way to put it.
Interesting. And I mean, obviously for andropause, also you've got the peripheral conversion, haven't you, of testosterone to estrogen, and so it's the aromatase enzyme that can occur in peripheral fat, and actually by intermittent fasting, you're going to be reducing that, which is going to have.
Well, it's the same process with women as well. Elevating your cancer risk and all of these things that again just mix with the problems in menopause as well. Yeah.
Let's talk about cancer risk. Okay, I'm going a bit off script because they haven't been asked. No one's asked this question yet. But let's talk about HRT and breast cancer.
Yeah.
And because that's the big question. Everyone sort of thinks, HRT is going to give you breast cancer. They also don't talk about the reduced risk of bowel cancer or hip fractures and other things. But just focusing on breast cancer, what are your thoughts on that?
Yeah, so the way I always describe it clinically to patients is that certainly for women up to the age of 50, let's say the average age of menopause, by which I mean that's the time of your last period, is 51 years old. And actually any HRT before then, when you're kind of topping up people's levels and stabilising their estrogen, there is no additional risks in that area. And the way I view it is that you're just replacing the hormones that you kind of should intuitively have, and you're replacing them in that way. After that, it's a much more balanced discussion. The studies show that there is no increased risk of death from breast cancer, which is a very clear distinction with HRT, but you really need to take someone in terms of their wider history. For example, as we discussed a little bit earlier about the kind of misinterpretation of data, which has caused so many problems around and fear around HRT.
It's all about the WHI study, aren't you?
Absolutely. So I think that caused a lot of that was a lot of scaremongering kind of off the back of that. But actually, these are very, very low risks, and there's some great resources that you can get online. And I've got like a saved tab on my GP desktop that shows per every 1,000 women, per 1,000 women in the age group of 50 to 60 years old, how many baseline would get breast cancer anyway, which is unfortunately extremely really common in the UK. The additional cases that we think are linked to HRT are very few compared to, I think it's over a 10-year period, there's like 4 additional cases for combined HRT. There's no additional risk with estrogen-only HRT, and that compared to obesity is like 24 additional cases. So it's all about context. And when I show people that, they sort of go, oh, okay. And actually, if I feel better and I can manage my obesity with HRT as part of it, then could I be optimizing other risks? And it is just about having that open discussion. If you've got a patient that's got a really strong family history, they're anxious, they want to guarantee no additional risk, then HRT is probably not for them. Okay, but it's on a case-by-case basis. And as you mentioned in your previous webinars, it is that change of focus from living longer to living better quality life, which is always the focus.
Yeah, absolutely, and that's a big focus in longevity medicine as well.
Yeah, absolutely.
And obviously we talked about breast cancer. The other big one is blood clots as well, isn't it? And this is the other big risk. And indeed, this happens for the oral contraceptive pill as well, isn't it? You get an increased risk of blood clots. Now, take us a bit more through that, because it's not always the case, is it? Depending on what regime you use.
Yeah, it's something that's actually just completely avoidable. So what we're really talking about is the risk with topical estrogen. So with topical estrogen, there is no additional risk of blood clots. And it's funny because you still get letters from different consultants saying, can you check this with a haematologist? There is no link there. There is, however, with oral HRT. And again, you mentioned the combined oral contraceptive pill. This is no surprise. Say in our medical training, you've seen so many people, coming through A&E, young ladies having had, massive pulmonary embolisms. People are still prescribing the pill every day. They have no hesitation to do so. I'm not saying they shouldn't, but there's significant risk there. And again, if your patient has got lots of comorbidities, things like that, I never start anyone on combined oral HRT because it's not necessary. Let's manage this risk in the best way that we can. And I think topical options are great for most people, and they like them. So
it all comes down to the sort of biochemical and the biomolecular understanding of how that works. Because if you take oral estrogen, you're going past that first pass metabolism. You're inducing your enzymes in your liver to make these clotting factors, which is going to cause clots. And now we understand that better. When the WHI study was published, we didn't necessarily understand that as well, but it's been proved in lots of big studies since then. As you say, there's no increased risk of blood clots. And in fact, there's a big study that's been out that's actually looked at bioidentical and body-identical hormones and breast cancer, and actually shows that there doesn't even appear to be an increased risk in breast cancer, which is a bit controversial because a lot of evidence is to say there is a slight increase, but actually it suggests that actually if you use body-identical and bioidentical hormones, then actually there isn't that increased risk. Now, I think one of the questions that came in actually is talking about body-identical and bioidentical hormones. Can you sort of talk us through the difference between them and how that relates to sort of normal traditional hormone therapy?
So I've got to say it's something that I don't have much experience in clinically. I come from a very NHS background with using kind of traditional HRT.
And the BMS teach a lot about synthetic hormones as well, don't they? They sort of teach that side of things.
Yes, and at the moment I think that it's an evolving area. There's people that have been prescribing it, having great results, people that didn't necessarily gel well with HRT clinically, but these things have been around for a long time, and I think it's an area that needs more evidence, it needs more research, as with often is the case with sort of new developing areas. But I think I'll be really interested to see kind of how that evolves over the coming years.
Yeah, I think it's a really interesting area of research, and certainly when we've been putting together these courses, we've been really, and I always say that we always try to cut through everything that's out there. So like existing schools of thought from the BMS, from existing marketing people who might be associated with certain companies who are trying to really push their products, like pellets and things like that. You've got to try and look through all that, and sometimes it is based on a lot of evidence, a lot of science, but what you want to do is go right back to those core papers, look at the literature, and it's quite interesting looking at body identical, bioidentical and traditional hormone therapy, and it's starting to be more of this sort of understanding about body identical, which is more, it's manufactured, so it's regulated by the MHRA and the FDA in the US. It's all sort of typical hormones, and it is sort of manufactured in bulk, whereas the bioidentical is more about these sort of compounding pharmacies who are making hormones specifically for one patient, and obviously those you can't do big scale tests on because they're making them just for that one person, aren't they? But
I think it all really comes down to, as well, with risk, it's all about what's the benefit. And so many of my patients over the years, they've gotten to, when they get invited to their annual HRT review appointment and get so nervous, and they come in as soon as they sit down and say, please doctor, please don't make me stop my HRT. I don't care what the risks are, you'll have to absolutely pry this out of my hands. They've got 60, 70, and again, there's so much misinformation about you. You can stay on your HRT indefinitely. Yeah. And that is
literally, you took the words out of my mouth. When do you stop HRT?
There is absolutely no point at which you have to stop HRT. I've had patients before that have been into their absolute later life years, and they are unwilling to continue. They don't care what the risks are. Yeah. They're unwilling to continue living because of the quality of life that they'll have without it. And I think patients should be, as long as they understand the risks and have capacity to do so. And again, there's been lack of evidence because GPs traditionally, by the time you got to 60, let's say, they'd say, well, you've been on it 10 years, so menopause has been and gone, we're done now. Here you go.
Are you serious? That is their mentality?
Yeah, end your prescription. Take it off your prescription. If you're 60, you can't still be in menopause. Yeah. Yeah. And unfortunately, the reality is for some women that the symptoms do settle. Some women get hardly any symptoms, if any. But for many, their symptoms will be absolutely enduring for the rest of their life. Yeah. Is the sad reality.
And I know certain groups of symptoms like the genital urinary syndrome and menopause are more persistent, aren't they, throughout life? Whereas hot flushes tend to sort of settle down over time. Yeah. But as you say, that can be completely debilitating. Low libido as well, we touched upon. All of these things that there's no reason not to carry on these treatments into later life. And again, we come back to the risks. If you use the right treatment regimes, they just really aren't there, and actually you can really benefit these patients.
It's the way we view aging, and this really ties into longevity so well. It's why it's so important. Is we have lots of assumptions again about people's physical ability, well-being, their physiological health at a particular age, but I think we see more and more now there's an ever-growing divide between people that actually look after themselves and know the right things to do and those that don't. So you can't just lump everyone into the same pool of patients.
Yeah.
Which I have to say is basically what you get in the NHS, I think, isn't it? We were chatting off camera before we started and said the NHS treats every man like as if they are completely identical, don't they?
Exactly.
Which is just, I've never seen anything so ridiculous in my life.
So we're getting loads of questions coming in, lots of questions coming in about CQC, which we will cover, and we'll cover sort of very shortly. We'll talk more about CQC in depth. But I just want to touch on one because, Abs, I want to sort of give you a bit of a question here to let you loose. So there's a question that's come in from Kane. So, do you cover the issues of testosterone to DHT, dihydrotestosterone, via SAR and the health issues associated with that?
We can do.
So, 5 minutes.
The thing with that is, to properly explain that, it would take a very long time. All I will say is, those conversion pathways and those enzymatic pathways exist purely as a dependent variable. They are not the controlling factor. They are dependent upon the metabolic pathways initially that then convert into the metabolites being used for certain things. So what you're studying there is not something to control. There is a hand at play which controls those things happening, and that hand at play, which is overarching over the whole thing, is more important, because if you get that right, all of the pathways there then are corrected. The difficulty with trying to act on that lower level, that dependent variable level in that kind of enzymatic pathway, is that if you try and fiddle with it, you are fiddling with that in isolation. However, in the body, that will never occur in isolation because lots of things occur at the same time, simultaneously. Like, you never get a single growth factor that's released. You never get a single hormone that is just increased by itself. Things always happen together. So the perspective to have is more important than how that pathway occurs. And the perspective to have is, what is everything that's going on at the same time as that on that level? And what is a level above that which controls everything below? Once we optimize that, you don't actually have to worry necessarily about the individual enzymatic pathways, because everything else is taking care of it anyway, if that makes sense.
I know we always talk about the piece of the puzzle, don't we? And
yeah.
These pathways, they're all just one part of the puzzle, because we're a very complex picture, and we're only really in regenerative medicine finding out the pieces that we're playing with. We still don't know what the overall picture is.
There's going to be an unlimited number of pieces to that puzzle, unfortunately.
Exactly. Yeah, no, absolutely. Good. So I think we've just got one more question I want to ask before we talk about CQC from Alma. So you're talking about PAP test screening before starting topical HRT and the need for that. Is that something we need to do?
That's not necessary. So there's not an association that you need to worry about. Do you mean more clinically? So one of the things that I was going to mention earlier, actually, for example, for women that do experience vaginal atrophy, find that often they stop going to their smear tests, so to their cervical screening, because having a speculum examination would be so deeply uncomfortable or even impossible that they stop attending. So it's actually a huge health risk there as well if they can't access that care. Or if they're having postmenopausal bleeding, big red flag, and again they think, I don't want to go and see my GP because this is going to be embarrassing, it might be painful. So the question really there is, no, you definitely don't need to. That's not part of the screening service, certainly in the UK. I know in the US, where you have more routine gynecology, I know there's a bit more of a regular kind of relation there. That's not the case certainly in the UK, but that's one of the things that can really benefit from vaginal estrogen pessaries, for example, is that it might allow women to have their smear tests again, even if they don't want systemic HRT. What we'll often do is put them on a 3-month period of vaginal estrogen replacement to actually allow them to be able to physically have their smear test and things like that done again. So a really, really good question. Yeah. I
think, and you touched upon vaginal estrogen replacement therapy as well. And is that something that you commonly have to prescribe patients in addition to the systemic HRT?
Yeah, absolutely. It's a bit like with testosterone. It's like one of those add-on pieces that people often miss because they don't like talking about it. They don't want to ask the question. Yeah. And again, that might play into what's going on with their sex life and their libido. They're like, libido maybe is fine, but having sex has been just incredibly uncomfortable, and etc. So yeah, it's really, really important. You've got to ask the question. You've just got to ask the question.
Brilliant. And I know a lot of the questions have been menopause related, so it's been really great to have you here, Harriet. So I think one last question, a bit about fertility, and actually more about the andropause side and the testosterone side. Is that a question that came in on the email? Is when you're taking testosterone, do you have issues of fertility?
Great question.
Testicular atrophy.
I'll put it this way: the youngest patient of mine that I have ever done true TRT on is 38, and he was done having kids, and that's why I felt comfortable doing that. TRT, if you do that, you do have to worry about fertility. The issue is if you put exogenous testosterone in there, the gonads think, oh well, we're incredible. Like, look at the level. We can just sit back and chill here. Like, what do they need us for? So then you get the atrophy, and that's where it comes from. But the issue isn't just the shrinkage; it's what it means for your ability to produce or to have children in the future.
Yeah.
Because if you're under the age of, generally speaking, around 40, it's, I know that's a variation of that, plus or minus, but you're probably going to think about kids at some point in your life. Personally, if I have someone who is much younger coming to see me and I ask them, do you want to have kids at some point in your life? And they say yes, I'll typically go more towards something like HCG, which essentially it mimics a hormone released by the brain, LH, and then that will stimulate the Leydig cells in the testes to produce their own testosterone. So you preserve fertility in that way. Now, depending on the dosage, you might a few hundred international units a couple times a week or daily, something like that. And when you combine that then with the diet and lifestyle, which is easier in that younger patient because they are more likely to be able to tolerate the gym, go more regularly, all these kind of things, you can treat them, you can give them that testosterone without having to sacrifice fertility. So it's a brilliant question. And because the possibility is there to lose fertility, we have other options as well.
And there are supplements and other things you can use to help
Yeah,
address
absolutely.
some of the symptoms of low testosterone, can't you?
Yeah.
So some things like physical performance supplements you can do
Yeah.
to help increase your gains in the gym.
I mean, if you're overweight, just getting to a normal weight range and reducing a super physiological amount of fat to a normal amount of fat, that alone is going to have such a big boost to your testosterone. People don't realize. Now, there is an exception to that. When someone is so big, they can't actually go to the gym, so they can't get started. And that's a call you make as a clinician. That's what you're qualified for. Barring those situations, yeah.
I mean, we talked about obesity in our last webinar. Obviously.
Yeah.
If you haven't seen it already, do check it out. It's on our YouTube channel, and that goes into a lot more about weight management. And it can be really hard for these patients who have either low testosterone or in menopause who have just been put down to the fact they're fat, and actually there could be an underlying cause here that might need to be treated. Brilliant. Well, I think I've put off the questions about CQC for long enough. So we'll talk a little bit about CQC. And what you actually need in order to prescribe hormones such as HRT and TRT. So the short answer is if a CQC is required for taking blood, so inserting anything or taking anything out of a body for diagnostic purposes, needs to be having a CQC registration, but you also need CQC for prescribing medications. Now, this can actually be looked at in a number of different ways. So one way is the full CQC registration. So we've done that for ourselves. It's not as laborious as I thought it was going to be. I thought it was going to be much harder, but actually once you've got the right forms for your clinic, it's actually much easier to get everything submitted. So CQC registration is one option. The second option that you can explore is actually having practicing privileges. So if you look at sort of plastic surgeons or doctors, they consult in hospitals that have CQC registration, but they themselves and their clinic doesn't have CQC registration. So it is something that you can quite easily get around without actually needing CQC registration themselves by finding a clinic that has CQC registration and getting practicing privileges. So if you're in London, very easy to do. There's loads of clinics all over Harley Street and the Medical Mile that you can get practicing privileges at the drop of a hat, and your CQC coverage is covered by them for both treatments you offer in that clinic and consultations you offer in that clinic, but also virtual consultations as well. So that covers you for having these virtual consultations, and that's a really nice, easy way to get around the sort of requirements of CQC. You're still being regulated, your practice is still being overseen by that clinic that you have practicing privileges with, because practicing privileges is different to a room hire agreement. Practicing privileges actually agrees that you're going to follow certain regimes and certain regulations within your own practice, which complies with the rest of the CQC. So there's really sort of two options there if you do want to go down the prescribing route and that side of things. For the blood tests, actually, we've got partners that we work with with Apex Medical that actually do a lot of that for you. So they take a lot of it away.
I can't imagine people probably doing that themselves. Just much more cost-effective ways, isn't there, to get your blood test taken and things. And I know that a lot of our viewers from last time were aesthetic practitioners as well. And I think the CQC could really, thinking about future-proofing yourself with your aesthetic practice, thinking could regulation come, and adding longevity to your work as well, it might just be time to bite the bullet and crack on with your CQC as well now.
Yeah,
really.
I think it's going that way, isn't it?
Yes.
I mean, certainly if you've got a big aesthetic practice now, you'd be silly not to get CQC
Just start.
regulation.
If you've got a full-time premises and things, I would think about just doing it.
Yeah.
And when people are interested in prescribing, can you just tell us a little bit about what the tick boxes are to physically write a prescription? Is it just a case of doing the course, getting the certificate, then getting the insurance, and then once you've got CQC, you're good to go?
Yeah, absolutely. I thought I was asking the questions here, Abs, but okay. So yeah, absolutely. So you obviously, we talk about it in our courses, but there is a checklist that you need to obtain. You obviously need your indemnity, your insurance. You need training. We talked about this earlier, didn't we, Harriet? Like, you can't do anything, no matter who you are, if you're not trained. If you're not comfortable giving these treatments, the GMC states you shouldn't be offering treatments. So you need the knowledge to do that. And then the CQC, either you need the CQC registration or you need the CQC partnership in order to provide prescriptions. And then from then it's actually really easy. So you can write prescriptions. There's a number of online pharmacies that we partner with. You write your online prescription, you send it off to them, and it gets dispensed. Everything gets handled by the pharmacy. So it's not about giving your prescription to a patient to go off to a pharmacy, and then a pharmacist who has no experience in HRT or TRT is like, what is this? We don't have this in stock, or we don't have Cypionate, for example, and they don't really, it causes the patient a lot of distress. So actually giving them this online option where it is just shipped straight to them is so easy. It works really well in my clinic, I know, and it's really, really handy to have that set up. And we do all of that with anyone who comes on our courses. And then the blood tests as well. We're talking about blood tests. So blood tests, again, we've got partners we work with. You can just request it online through your own clinic portal. They then liaise with the patient. They set up when the blood test is going to be. They send out all the reminders. They bring them in. Not only do the blood test, but they do body composition analysis. So they look at everything. Look at visceral fat. They look at superficial fat. They look at everything. They look at blood pressure, they look at height, weight, they look at all these things. So you can actually effectively run a completely online service because you've got a clinic there that's offering it. And the partners that we work with have clinics all over the UK.
It's going to be so much better for your patient as well. They're not going to be, I'm only in clinic Tuesdays and Thursdays. They can go on a Saturday. They can probably have way more appointments, locations. And again, that means that, no matter where you live in the UK, that really widens your potential patient pool as well, you can be seeing someone who doesn't live in your vicinity, different city even.
Exactly, and we talk about it on the courses, but there's a very clear patient pathway, sort of 5 steps where you go from that initial intake form where you're gathering all that initial data and deciding what blood tests they might need. Second step is going for those blood tests. So you don't necessarily have to have seen the patient yet. You're sort of looking for that intake form. Some people might supplement it with a short little consultation to just clarify anything on the intake form. Send them for that blood test. They go off and they go to the clinic. They get their composition analysis. They get their blood test, or they even sometimes can do a home test for patients who aren't near a clinic, which is really handy. They get that analysis done. Then they come in for the consultation, or they see you virtually for that consultation. That's your third step. Your fourth step is then writing that prescription. Your fifth step is your ongoing support and follow-up. And it's really quite a straightforward pathway for these patients. It's really easy. Once you understand it, it's really easy to set up in your own clinic. So I think we're on what we want to sort of do at Apex Medical. Obviously, what we're passionate about is getting more people into longevity, because it's a really new field that is gaining so much more attention. The media seems to be publishing something about longevity almost every day now, and actually it's getting to the point where it's quite embarrassing for healthcare professionals because patients know more about it than us. And I don't know, but I certainly, even in my NHS practice, people are starting to talk to me about some of these treatments like NAD. And I had a patient the other day who had injured a hand, and they were asking me about NAD treatments. And I was like, yeah, and I was like, wow, I must have watched one of your podcasts. and the patients are starting to educate the doctors, and what we're trying to do is catch up the healthcare profession. So we've made partnerships so that we can start training people, where a nurse, a pharmacist, physio prescribers can do this if they're prescribers and they're trained in this area. Doctors, obviously dentists, like us, we can prescribe these medications. So we get insurance. That's not a problem at all. CQC, we work with two partners essentially who you can either get CQC registration yourself, and if you want to do that, then all of the people who sign up to our courses get the community access, and on that they get all of the documents for CQC registration, so they don't have to do any work. The CQC registrations documents are given to them, the template, they can put their own clinic details in. They also get support with actually completing that form themselves, writing that form, submitting that to the CQC, and then going through the interview process. If you're doing a completely online clinic, it's a really easy process because it's not exactly got any clinic to inspect. So all of that support we offer as part of our community membership, which is a really, really good option. So at the moment, as you know, with our pre-launches and our launch packages and our pre-orders, you get lifetime access to that community. So it's not just 6 months that you would normally get through courses and 6 months support that we get normally from aesthetic training, and you would get after the pre-order when it closes. So it is something you get lifetime access during the pre-order window. So that CQC support alone is worth its weight in gold. But then for people who actually just don't want to do anything regarding CQC replacement, we actually work with partners who will take that all off them and reintroduce them to, you've probably heard of some of the companies that do it, and they will essentially take that off them and do that for them. But it's actually not as hard as you think, and actually just doing it yourself with the template protocols and things is quite easy. For people who want to go down the practicing privileges route, we also partner up with people who offer practicing privileges on Harley Street or in London. It's a main area that we sort of know people at the moment, but obviously we're expanding that. So people want to go down that route, again, really easy route to at least get started before you start getting your own CQC. So CQC is one of the big questions. Obviously, for doing longevity medicine, you don't have to have CQC. You don't even need to go down this route at all, do you? And Abs, you'll tell us a bit more. Like, what's the main?
Absolutely, you don't need to do that.
To your patients?
Diet and lifestyle. I feel like, again, it sounds like a broken record, but for me, like, I emphasize diet and lifestyle so much that if they're not willing to make those changes, I actually don't see them as a patient. And when I emphasize it that much and I really understand the importance, a lot of what they came to see me for in terms of improvement in sport, improvement in mental focus or weight loss or anything like that, we correct that before we even go any higher up the pyramid, because everything else self-corrects. And for that, like Matt says, I don't need CQC to give diet advice and tell people, not to eat McDonald's every day. It's a pretty simple process, even internationally, right? I mean, some of my patients now are in the Euros right now, so I can have a Zoom call with them, day before a match or a week before a match or whatever, and I don't have to worry about international laws of medical qualifications and being valid in different countries, because I'm just talking to them about basic things at the end of the day.
And that's the key thing is after this training you can still give advice, you still do consultations in all of these areas, and you can still do blood. You can send them off to the partner for their blood test, because that's all CQC registered with them. So you can actually, without even bothering with CQC, still offer quite a complete longevity service.
And even on the blood test, if people are put off with the CQC and you want to at least get into things like the blood testing and the DEXA scanning, all that kind of stuff, technically you could actually just say to your patient, I advise this. And there's nothing wrong with that. And say, look, can you get this done and just tell me what the results are if you're happy to do that.
I've seen people do that as well. And
that's what I do.
You can actually go to Lloyd's Pharmacy online and you can get your own HRT through a simple form consultation, can't you? And you can actually advise patients, look, I think this is something that would be beneficial for you, have a look at this.
I think the other side of things as well, from a kind of particularly with menopause patients, what I've seen, but I think longevity really as well, is that we're, as our kind of medical view of patients, we're focusing on advice and disease and fixing things. I think one of the most crucial parts of this that we haven't really spoken about too much yet is the power of just listening to your patient.
Absolutely.
The vast majority of what you need to know, we started this webinar talking about what are those early signs. You need to listen, which is, again, I think we're not always the best at. Collect that information, ask the right questions, and just showing your patients some compassion, understanding their situation, as you mentioned, like with the weight loss, really listening and understanding the patient and giving them that time is the foundation to really, really work together and to get.
It's the biggest difference between NHS and private, right? Because you don't have the time for that in the NHS.
Right.
As soon as you just shut up and let the patient get load off their chest,
why I always
it's
run
worth
late
the money.
hours. So my patients will wait, but I do always run late.
Yeah, it's true. So I think that final thought, we've got to close up now. So it's really, there's a lot of people who are asking, how can I get started in HRT and TRT? And I think, obviously we are a training academy. We're a very impartial training academy. We pride ourselves on not partnering with any sort of big supplement companies or certain tests or anything like that, because we don't want to be pushing a certain agenda. What we want to do is look at all the evidence, look at all the science, and just convey that in a way that you can actually take away and put into practice and put into a clinical practice. And a lot of people I think are quite surprised, but hopefully reassured from hearing from you, Harriet, about that actually you don't need a lifetime training in menopause to offer menopause treatments and menopause consultations. And actually, with the packages that we offer, is more than enough training in menopause and TRT to actually go out there and start offering these treatments safely and effectively.
Oh, Matt, as a say, completing this course, you would have been had better and more kind of focused HRT menopause training than I had as a GP trainee. Honestly, it's it doesn't have to be complicated, and it's not as scary as you think. So one last thing then just to say really is just to talk about the offers that you've got at the moment. So to the end of this week, so for the next 4 or 5 days, we're still running our pre-orders. And the big seller at the moment, the one that people are really interested in, is the exclusive launch package, and that's basically including everything. So that's
the foundation course, which covers TRT, HRT, diet and lifestyle. The advanced course, which covers all the weight loss treatments we talked about in the last webinar. It covers the performance optimization, medical, physical, and it covers the healthy aging sort of aspect of things as well. So the whole pyramid is going to be covered with these 2 courses.
Don't know, it's everything.
So yeah.
Okay.
So you've got everything there in that foundation advanced course. So it's a really good course, a really good way for people to get into longevity. But not only does it include that, for the pre-order window, we're also offering the live-in training with us. So we're actually going to be giving some guidance to you guys and getting real patients in for you to consult. So you can actually leave that day having treated a lot of patients, so you can go home and you can just be confident, say, well, yeah, I can manage menopause. What's all the myths around menopause? What are the myths around TRT? I'm very comfortable offering this. So that's going to really kickstart people's career into longevity medicine. And then also, obviously, I talked a bit about the communities feature. So the communities feature is a place for everyone interested in longevity really get together to put up cases that are interesting. Obviously, we're going to be there moderating. We can provide our advice about how we might manage that case. But it also includes monthly webinars, so private webinars, Q&A sessions, small group Q&A sessions with us. We're going to talk more about sort of how they can manage certain cases, how they can manage certain aspects of their clinic, how can they build and grow their clinics. All these things on a monthly basis we're going to be helping you guys with.
Was there a dinner or something?
Dinner with it, a potentially option of the VIP upgrade. Yeah, I wasn't going to talk about that, but there is a hotel and dinner package as well, which will be sent out soon, because that's something we're going to have. We're going to do ourselves anyway. So we're going to invite people along to join us for that, chat more things longevity. But just back to the communities. I mean, that whole thing in itself, the CQC support that you get, all of the other extra things you're going to get from that, and with any of the pre-orders, you get lifetime access to that. Which is going to be 6 months once we open our courses live. So actually, this is a really good opportunity to jump in on the ground floor and be a member of a community for the rest of your longevity career. So it's a great opportunity, guys. So really do look into it. And I really want to thank Dr. Harriet for joining us today. And
it's been a pleasure, guys. Thank you for having me.
It's been a real pleasure. And thank you so much for your insights on menopause. And Dr. Abs, as always, we've tolerated it.
I've reined it in today. They've allowed me to come in. I may be allowed back.